Erythropoiesis, as the term suggests, erythro or erythrocyte refers to red blood cells, and poiesis, the growth, development, and maturity of cells. This is what we're going to talk about in this section. The morphology of the red blood cells, it appears as a biconcave disc. It doesn't have a nucleus, and its lifespan is 120 days. The earliest cell that we refer to that is going to provide this lineage of cells is called the reticulocyte. The mature form of the cell is referred to as the erythrocyte. The primary role of the red blood cell, as you know, is to carry oxygen to the tissues and remove CO2 as a waste from the tissue. It also has a role in buffering. The erythropoietin is the hormone that's primarily responsible for stimulating the production of red blood cells. You may also recognize it as a drug that we give to patients that have a low erythropoietin level. When present, this hormone will activate or stimulate production of this cell line. There are about 2 million red blood cells produced every second. What controls the rate of red blood cell production? We've already mentioned erythropoietin. Another stimulant of red blood cell production is low oxygen. So low oxygen will stimulate the release of erythropoietin, and erythropoietin will then stimulate the bone marrow to produce more red blood cells. The erythropoietin comes from the kidney. That explains why patients with chronic renal insufficiency and renal failure have low levels of erythropoietin. These patients will receive a replacement drug, Epoetin, which can assist in stimulating bone marrow production in the face of low erythropoietin levels in these patients. The other requirement for red blood cell production are shown here: iron, B12, and folic acid, common vitamin supplement. We then produce new reticulocyte. Hopefully we don't have failure of cell production, and then the red blood cells will enter here. It's shown as part of the total red blood cell volume, which will then become part of our circulation. Old red blood cells, or cells that are injured, will periodically enter the spleen, and they will subsequently be removed from circulation. The other way that red blood cells can be destroyed is through the process of hemolysis, and this can be in the circulation. Another example of loss of red blood cells is hemorrhage, and that's through blood loss from injury. This next slide is about the erythropoietin hormone and its effect. You have the brand names. Epogen and Procrit are the most common. When they are given, and these are drugs that are given to patients who have renal disease, still require this hormone to stimulate red blood cell production. The way that the drug is made is through DNA technology, recombinant DNA technology. The uses, as I mentioned, chronic renal failure, chemotherapy-induced anemia, HIV patients on this particular drug, which can cause loss of red blood cells through hemolysis, the anemia in patients facing surgery. So sometimes this drug will be given to assist with the production of red blood cells in patients who are anemic, that are undergoing surgery, that would rather not take a blood product. There are some adverse effects to Epoetin alpha or erythropoietin, the drug. It can result in hypertension, autoimmune disease, and it can result in cardiovascular events. Perhaps the most feared would be these thrombotic events. The dosage, so to minimize the risk, we use the minimum amount to obtain the red blood cell count that we need. Transfusions with blood products, they are also associated with risk. So this is an alternative to that. but we will use the minimum amount of this drug needed in order to obtain the hemoglobin, an appropriate hemoglobin count. And that to get the patient to a 14, typically 12 would be sufficient in most individuals. It would certainly be sufficient preoperatively. And then we can monitor the hemoglobin and hematocrit to make sure that ideally after giving this drug, we see a sustained increase, no ongoing hemolysis or destruction. We would expect that the red blood cells that are made, we know their lifespan is 120 days. So we would expect these patients to have a sustained level of their H&H over that time period. There are other essential elements that are needed for normal red blood cell production, and that is vitamin B12, folic acid, hemoglobin, which is the carrier protein for oxygen, and iron. So all four of these, B12, folic acid, and iron, well-known components of multivitamins that we take, and then hemoglobin. B12, for most patients, we can obtain from a dietary source. If not sufficient, we can supplement patient with a multivitamin, or even B12 can be given alone as a supplement. It is typically stored in the liver. It is important to remember that it is bound to intrinsic factor, which is produced in the stomach by the parietal cells. B12 is absorbed with intrinsic factor. So you may get a question which would ask if the patient would be affected by a procedure which would remove the terminal ileum. What vitamin deficit would we see? The answer is B12. That's a common test question. What are some consequences of B12 deficiency? Well, immediately you're probably thinking anemia would be a consequence, and that is correct. In particular, B12 deficiency results in what we call megaloblastic anemia, where the cells are larger than normal. Formation of that portion of the intestine where B12 and intrinsic factor would be absorbed. Celiac disease, because of its involvement in the intestine, how its effect on the intestinal lining, it impairs absorption, and the absence of intrinsic factor. Consequences, as I know, megalo refers to large, blastic, young. So we have an anemia that when we look under the cells are large and immature. This is a sign of vitamin B12 deficiency. The other side effect of B12 deficiency is neurologic damage, because B12 is needed for normal development of myelin, which is the sheath surrounding neurons, and that enables the action potential. So demyelination of neurons results in neurologic damage. GI disturbance can also result. The diagnosis is two ways. Measuring plasma B12, so we can simply order a B12 level on the patient, and we can do another test which is called the Schilling test. When vitamin B12 is low, we can replace the vitamin, and that can be done orally, it can be done intravenously, or even intranasal. The side effects are hypokalemia, or a low potassium level. Long-term treatment with a lack of intrinsic factor would be B12, and that would be therapy that is lifelong. The scenario where you might see a lack of intrinsic factor is a patient post-gastrectomy condition, which would limit the intrinsic factor produced. And that is because intrinsic factor and B12 are absorbed together in the terminal ileum, so we need both. So if we have a condition that affects the region of absorption, enteritis, or we have a deficiency of intrinsic factor, then we are going to affect B12 absorption. That's the other presentation that you could be given on the exam.